Good morning. I'm Amy Rowley McGee, the president of the Health Policy Institute of Ohio. Thank you for joining us this morning for our online forum and the release of HPIO's 2021 Health Value Dashboard. The mission of HPIO is to provide the analysis needed to create evidence-informed state health policy that improves health value. Thank you to our core funders who advance our mission through their steadfast investments in our work. Thank you to our 2021 Forum Series sponsors for their generous support. And last, a special thank you to the Health Action Council for providing funding for the 2021 edition of the dashboard. We encourage you to tweet throughout today's webinar using the hashtag HPIO Forum. If you have questions for presenters, please type them into the question box. Today's presentation slides and other related resources, including the final hard copy version of the dashboard, will be available on the HPIO website and can be found by clicking the Events tab. The 2021 Health Value Dashboard is the fourth edition of this publication. HPIO is committed to continuing to update the dashboard every 2 years so that as a new biennium begins, state policymakers, state government leaders, and others who influence the policymaking process can use it to gauge progress. While improving health value requires action from both the public and the private sector, federal, state, and local policies are important and powerful levers for improvement. The dashboard is based on HPIO's Pathway to Improved Health Value framework. The framework defines health value and outlines the systems and environments that affect health. Improved population health and sustainable healthcare spending are the ingredients of improved health value. We'd like to get a sense of how you all think Ohio performs on population health. So please take a moment to respond to the poll question here that you see. How does the health of Ohioans compare to the health of people in other states? So please just choose what you think is the most accurate response. And then we'll also go on, our next question will be about how you think we perform on healthcare spending. So Alana, you want to show the results? All right, so it looks like well over half of you, almost 70% of you, believe that we are worse, have worse health than most other states, and about 13% of you think that we're at the very bottom. All right, well, let's now move on to the question about how Ohio performs on healthcare spending. All right, so what are your thoughts here? Do you think our healthcare spending is lower than most other states, in the middle, or higher than most other states? Please just take a second and select a response there. Hey, Alana, can you show us the results? All right, we're a little more evenly distributed on this question, but well over half of you believe that our healthcare spending is higher than most other states, and about a quarter of you think we're in the middle. Well, let's now go on to share the results from our analysis of the data in the 2021 dashboard. So this analysis found that Ohio ranks 47th out of 50 states in the District of Columbia on health value. We rank 43rd on population health, so in the bottom quartile, and 37th on healthcare spending, which is the third quartile. This means that Ohioans continue to live less healthy lives and spend more on healthcare than people in most other states. Ohio ranks in the bottom half of states for 4 of the 5 systems and environments that contribute to health. Access to care is our only relative strength. My colleagues and our guest speakers are going to explore Ohio's performance in depth and highlight opportunities to improve. I'm pleased to introduce my colleagues, Reem Ali and Amy Bush-Stevens, who are both Vice Presidents of Policy at HPIO, and Zach Reet, who is the Director of Data Management and Analysis at our organization. While the creation of this publication is truly a team effort, I'd like to particularly extend appreciation to Zach for his leadership on the 2021 dashboard. So we're going to start with Reem. Reem, take it away.
We're actually going to start with Zach.
Oh, I'm so sorry. We're starting with Zach.
Thanks very much, and thanks for those kind words, Amy. And thank you to all of you for joining us. I am Zach Reet. I'm the Director of Data Management and Analysis, and I'm going to be taking you through an overview of the dashboard and talking about the bright spot for Ohio. Reem is going to point out 3 reasons why Ohio, again, performs poorly on health value, and then Amy Bush-Stevens is going to outline 3 opportunities for improvement through policy. So the dashboard would not be as effective without input from members of our advisory groups, particularly the Health Measurement Advisory Group and the Equity Advisory Group. And many of the advisory group members are with us today, and we're very grateful for all of your contributions throughout the years on the dashboard. We again partnered with Ohio University and Dr. Ani Ruhil on the analysis for this edition of the dashboard. This is the 3rd edition that we've partnered with the team at OU, and again, we're very grateful for their contribution. So with each edition of the dashboard, HPIO has worked to improve the messaging about Ohio's greatest health challenges and opportunities for improvement. And we've done that while trying to minimize changes to the metrics and methodology. In the 2017 dashboard, we added equity profiles to identify gaps in outcomes for some groups of Ohioans. And the biggest change in the 2021 dashboard was significantly increasing the number of metrics that we analyzed for disparities in those equity profiles. So the impact of COVID-19 on the health and well-being of Ohioans can not be understated. So for example, here in the US, it's estimated that life expectancy could decrease from 2019 to 2020 by more than 1 year. And the impact will be even greater for Latino and Black Americans. But due to some issues with data lag, most of the data in the 2021 dashboard doesn't reflect the impacts of COVID-19. We do, however, have a commentary on how COVID-19 has impacted the factors that contribute to our health, and those include employment, education, the public health, and the healthcare systems. We also talk about how COVID-19 could widen inequities that contribute to our health, and here's just one example of that. Unemployment in the state of Ohio increased from 4.9% in March of 2020 to 16.4% in April. For people who have lost a job during this pandemic, the challenge of recovering that could be much longer lasting than the pandemic itself. So earlier, Amy showed you a slide with Ohio's ranking on all of the dashboard domains and pointed out that Ohio ranks well relative to other states on access to care. Ohio is 7th out of the 50 states and DC. And over the past decade, there's been a lot of major policy changes in this area, including the expansion of Medicaid eligibility in 2014. There's also been efforts to increase access to primary care and a lot of focus on increasing access to addiction treatment. So the success that we've seen in access to care is really a testament to the power of policy, and it's an important success story to be told in Ohio. And here's one example of data that helps to tell that story. So Ohio's uninsured rate went from 14% in 2008 down to 8% in 2019. And during that same period, the gaps in outcomes by race and ethnicity and income also moderately narrowed. So we know, and we often say that access to care is necessary, but it's not sufficient for improving overall health or health value. We can, however, in Ohio, draw on our experience of improving outcomes and access to care through policy attention to drive improvements in the other domains that impact our health. And at this point, Reem's going to take it over and talk about 3 reasons why Ohio ranks poorly on health and health value. So again, thanks for joining us, and take it away, Reem.
Thank you, Zach. In examining the data in the 2021 dashboard, we found that lack of attention and effective action across these 3 key areas was driving our poor health value rank, and I'll share more data and information behind each of these. I'll start first with our lack of attention on childhood adversity and trauma. Ohio is in the bottom quartile, ranking 39th out of 50 states and DC on the percent of children who have been exposed to 2 or more adverse childhood experiences, or ACEs. And what this means is that 1 in 5 children in Ohio are exposed to multiple adverse events, things like child abuse and neglect. Notably, Ohio also ranks in the bottom half, sometimes the bottom quartile of states on several risk factors for ACEs that you see here. So for example, Ohio ranks 47th out of 50 states and DC on drug overdose deaths, which suggests that children in Ohio are at a greater risk of exposure to substance use by a household member, which is another type of ACE. The research is clear that ACEs can have both immediate and long-term negative health as well as economic impacts, and those impacts can persist across generations. Based on analysis that HPIO conducted earlier this year, we found that more than $10 billion in healthcare spending and $319 million in lost wages could be saved annually if specific ACEs were eliminated. Across the equity profiles in the 2021 Health Value Dashboard, Ohioans of color, with disabilities, and with low income or educational attainment consistently had worse outcomes. And the research evidence is clear that racism and other forms of discrimination, such as ableism, xenophobia, homophobia, ageism, are individually and in conjunction with one another systematically disadvantaging these groups of Ohioans. And as demonstrated in this framework, racism and other forms of discrimination can impact health both directly and indirectly. To give a clearer picture of what this looks like, on the left side of your screen, you see that compared to white children, parents of Black children in Ohio are 17 times more likely to report that their child was treated unfairly due to their race. What that means is that 1 in 10 Black children in Ohio are being treated unfairly, and that's 1 in 10 again. On the right side of your screen, you can see how experiencing racism directly impacts health and can have longer-term consequences, with Black adults in Ohio being more than 5.5 times more likely to report physical or emotional symptoms as a result of treatment due to race. That would be 1 in 5 Black adults in Ohio. These measures paint a picture of how pervasive racism is in our society. And although we don't have measures for other forms of discrimination, such as ableism, the research indicates that they bear similar impacts. In addition to the direct impacts of racism and discrimination, poor outcomes are fueled by policies, systems, and beliefs that unfairly disadvantage some Ohioans over others, resulting in inequities across community conditions. An example of this can be seen in food insecurity, or a measure of families that sometimes or often cannot afford enough to eat. Children of color, children living in low-income households, and children with disabilities are all much more likely to experience greater food insecurity than their peers. Here's another example. COVID has really brought to bear the importance of broadband access for school, for work, for healthcare, and again, for Ohioans of color, as well as Ohioans without a high school diploma, the inequities are striking. If this gap was eliminated, more than 238,000 Ohioans with less than a high school diploma would have broadband internet access. Then we get to our third reason why, which is that because of our sparse public health workforce, we have missed opportunities for prevention. There is a limited investment in Ohio in our public health infrastructure, and we rank 48th in state public health funding and workforce. Only 3 other states spend less on public health than Ohio, and consequently, in recent years, we've seen that our state public health workforce has actually declined. As a decentralized state, our local health departments are a critical part of Ohio's public health infrastructure, and per capita funding for local health departments in Ohio, as you can see here, is lower than the US overall. And our local health departments are largely reliant on funding that they get locally. And because of this, the capacity of local health departments can vary widely across the state. Low investment in public health has led to missed opportunities for community-based prevention. And Ohio ranks primarily in the bottom quartile of states on measures of addiction and chronic disease, measures that could be improved by strengthening community-based prevention. As an example, we talked about this in 2019, and here it is again in 2021. On the left side of your screen is a map of what is referred to as Tobacco Nation, or states with the highest smoking rates. And then on the right side of your screen, you see a map of states that are in the bottom quartile on population health in the 2021 Health Value Dashboard. What this tells us is that our lack of attention and focus on community-based prevention to reduce tobacco use is clearly correlated with poor population health outcomes and is driving poor health value. Now, my colleague Amy Bush-Stevens will talk more about policies that can drive change and move us in the right direction.
Good morning, everyone. Thank you so much for spending part of this beautiful spring day with us. Now that Reem has shared the 3 reasons why Ohio performs poorly on health value, I'm going to talk about how we can turn that around and improve. In the dashboard, we highlight these 3 policy goals listed in blue on the right. And then we get even more specific with 9 policies that work to improve health value. And I'm going to give a few examples of these policies. Starting with the focus on children and building family resilience. And this is critical because, as Reem mentioned, childhood trauma can carry forward across generations, so it's important that we intervene early. Even before COVID-19, we had troubling disparities in reading proficiency and chronic absenteeism in our schools. And because of the learning disruptions caused by the pandemic, these disparities are only getting worse. A recent OSU study found that declines in 3rd grade reading were most pronounced for students of color and economically disadvantaged students. And we know that educational attainment is such an important factor for health. So helping these kids to catch up should be one of our top policy priorities this year. We can do this by making sure that our federal COVID relief dollars are targeted at things like high intensity tutoring and chronic absenteeism interventions and trauma-based counseling for kids who have experienced adversity, disruption, and learning loss. The second policy goal focuses on equity. There are many ways that racism and other forms of discrimination affect community conditions and our health outcomes. And in the dashboard, we focus specifically on how institutional and structural racism affect housing. Housing cost burden contributes to health disparities like what we see for infant mortality. 30% of Black Ohioans spend more than half of their income on housing. This contributes to persistent stress, which is not good for health, and it also crowds out spending on things like food and healthcare and saving. Rental assistance initiatives like Healthy Beginnings at Home in Columbus are one example of a way to address these challenges. Led by Celebrate One, Healthy Beginnings provided rental assistance and other support to homeless and unstably housed pregnant women. And then researchers have been tracking outcomes for these families compared to a similar group of families that did not get rental assistance. And as you can see from the bar chart on the right here, the Medicaid spending was almost twice as high for the families that did not receive rental assistance, largely driven by higher NICU spending for the control group families. The third area is prevention and public health. As Reem mentioned, Ohio has a smaller state public health workforce per population. Only 3 states have a smaller state per population public health workforce. So it's critical that we increase the size and the diversity of our public health workforce at both the state level and the local level. So here's just one example of the strain on our local public health workforce here in Franklin County. Childhood immunizations are a highly cost-effective prevention service, and Franklin County Public Health has been providing a safety net childhood immunization clinic for many years that largely serves uninsured families and low-income families. Because of the pandemic, they had to shut down the childhood immunization clinic because they simply didn't have the workforce to keep it going. The result will likely be an increase in the number of vulnerable kids who are not immunized. We also need to think more creatively about how to sustain community-based prevention. And one idea is to dedicate a portion of future revenue from tobacco and alcohol taxes, opioid settlements, and pandemic relief towards addiction prevention and treatment. There are many reasons why Ohio performs poorly on health value. And just to recap here, these are the 9 policies that we highlight in the dashboard. These are important because Ohioans are living less healthy lives and spending more on health care than people in most other states. And again, there are many reasons why we perform poorly, but fortunately there are proven approaches to help us improve. As we look forward to what Ohio is going to be like after the pandemic, we need to continually ask ourselves how we can reopen and rebuild in ways that will make us a leader and not a laggard in health value. Our 3 speakers today are going to help us reflect on where we've been as a state and as a country over the past 8 years, and how we can use the power of policy to get Ohio into the green. And I'm now going to turn it over to the other Amy and see if we have any questions.
Yes, thank you, Amy, Reem, and Zach. Let's see, I'm not seeing any questions other than there was a question about posting a link to some research that Amy Bush Stevens referenced. So we'll follow up with that shortly. A reminder to please put any questions into the chat box or into the question box, and we'll monitor those and pause for responses to those questions periodically throughout today's webinar. Moving on, we're pleased to have Dr. Sarah Collins with us this morning. She is the Vice President of Healthcare Coverage and Access with the Commonwealth Fund, and she's going to take a look back at improvements in access to care that have happened over the last decade or so to emphasize the power of policy. Good morning, Dr. Collins.
Good morning. Thank you, everyone, and to the Health Policy Institute for the invitation to join you today for this timely release of your 2021 Health Value Dashboard. I'm going to provide, as Amy said, an overview of policy effects focusing over the last 10 years, focusing particularly on insurance coverage and access to care in the United States. And why progress in particular has stalled somewhat over the past few years, and what we can do to reignite the progress that we saw earlier over this last decade or so. Oops. Depending on which federal survey you use, there are about 30 million people who are currently uninsured in the United States. In the absence of the Affordable Care Act, according to CBO projections from prior to the major reforms that went into effect in 2014, about twice that number of people would have been uninsured in 2019. But if you look at the dotted line, CBO is projecting that the number of uninsured will likely remain steady at about 30 million through the end of the decade in the absence of future policy changes. The gains in coverage from the ACA expansions occurred in every state after 2013, but after 2016, there's somewhat of a different story. In about half the states, there was little or no change in insurance coverage, and in half the states, coverage actually worsened. Ohio is one of those states. This is for the 19 to 64-year-old population, so it's a little bit different point estimate than in the dashboard. But it's important to note that Ohio cut its uninsured rate in half in this age group after 2014. Ohio expanded eligibility for Medicaid, so it dropped to about 8 percentage points. The rate right now is in this age group is about 9.2%, but it's low relative to the national average of 12%. And as the dashboard indicates, it's about 8% for the under 65 population. And it's about 5% for children, which is right at the national average. I'm going to take later on in the presentation, I'm going to take a closer look at the remaining uninsured. The primary purpose, of course, of insurance is to enable timely access to healthcare. In most states, access improvements after the Affordable Care Act followed a pattern similar to insurance coverage. The share of adults who reported going without care because of cost declined in a majority of states through 2016. But after 2016, you can see the changes in the map. Adults in 21 states experienced little or no improvement on the access measure. In 15 states saw a rise in the share of adults going without care because of cost. Ohio actually improved a little bit, at least in this measure. State decisions to expand Medicaid are associated with a lot of the variation in coverage and access to care that we see across the states. 14 states have not yet expanded, and this includes 2 states, Missouri and Oklahoma, that have passed ballot initiatives to expand but have yet to do so. There are an estimated 2 million people who fall into the so-called Medicaid coverage gap. They're ineligible for subsidies through the marketplaces because their income is too low, it's under poverty, but they're also probably earning too much or not eligible for traditional Medicaid in their states. These non-expansion states include 2 of the most populated states in the country, Texas and Florida. Texas has the highest uninsured rate in the country at about 1/4 of the adult population. Of the estimated 2 million people in the coverage gap, about 1/3 of them live in Texas. Ohio, again, as you can see from the chart, has an uninsured rate that's below the national average. The ACA coverage expenses, as the value dashboard indicated, has led to significant improvements in coverage among people of color, as well as white adults. These gains also led to a significant narrowing of wide disparities in coverage and access between Black and Hispanic adults and white adults that existed prior to the Affordable Care Act. But like the coverage gains, reductions in racial and ethnic disparities have stalled since 2016. In 2018, there was a disparity in coverage of at least 5 percentage points in 17 states. In Ohio, it was 4 percentage points between white and Black uninsured rates and 12 percentage points between white and Hispanic adult uninsured rates. I'm going to shift now to what Americans pay for healthcare and their health insurance. More than half the US population gets their coverage through an employer, either their own or that of a family member. Employers contribute about 80% on average of premium costs, but that varies a lot by state, by type of business, and also by single and family coverage. While this amount of cost sharing or premium cost sharing by employers hasn't changed a whole lot over time. Overall premiums have grown over time, and the amount that employees contribute to the premiums has grown as well. And because income growth has been relatively stagnant over the past decade, employee premium contributions as a share of median income have also risen. As premium costs have risen, employers have also increased the size of their deductibles in order to share more of that premium cost with their employees. In 2019, employer premium contributions amount to 6.8% of median income across the country, and deductibles nearly 5% of median income. The combined cost of premiums and deductibles was 11.5% of median income, which is up from about 9% a decade earlier. In Ohio, the combined number is about 10.6% of median income. Using our biennial health insurance survey, the Commonwealth Fund has been tracking the number of people who have insurance but face such high out-of-pocket costs relative to their income that they're underinsured, or they have high deductibles relative to their income. We use the measure of deductible and out-of-pocket costs over the past year as a share of income. About a quarter of the adult insured population is underinsured. People with individual market coverage are underinsured at the highest rates. That would include marketplace coverage. But the largest growth over time that we've seen has been in employer plans, and this is mostly driven by the size of people's deductibles. So what's driving growing coverage costs in commercial coverage? Health spending is the primary driver of premiums and deductible sizes. As costs rise, so do premiums and deductibles. So what's driving costs in commercial insurance? There is considerable evidence right now that the major driver in prices chart, the major driver of premiums and healthcare costs overall are prices charged by providers, particularly hospitals. Compared to what Medicare pays, prices for hospital inpatient care paid by commercial insurers are higher than Medicare prices in every state. In Ohio, they are 220% of Medicare prices. This scatter plot shows the association between higher prices for healthcare services and employer premiums. Higher state commercial provider prices are associated with higher premiums. So the implication is that to lower premiums in commercial coverage and lower deductibles, we need to address prices. Subsidies, marketplace subsidies, protect consumers, but higher prices also lead to higher federal costs. I'm going to wrap up with a look at the remaining uninsured and health policy reforms that can reduce the number. These new estimates from the U.S. Department, from HHS, show that of the 30 million or so people who are uninsured in 2019, 11.2 million had incomes that actually made them eligible for subsidized coverage through the marketplaces, and 3.6 million had incomes too high to qualify for these subsidies. Some people in this group may have also had offers of employer coverage and are not enrolled. In Commonwealth Fund surveys, affordability, lack of awareness, and confusion over eligibility are the major reasons why uninsured people don't sign up for the coverage that they're eligible for. 6.4 million people are eligible for Medicaid or the Children's Health Insurance Program, but are not yet enrolled. The same issues about confusion about eligibility, enrollment barriers also drive this issue. But about 5 million uninsured people with incomes under poverty live in the 14 states that have not yet expanded Medicaid. They're not eligible for marketplace plan subsidies, but they may be eligible for their existing state Medicaid program. And about 3.1 million uninsured people are undocumented immigrants. The Biden administration has taken several actions to encourage more enrollment in the marketplaces, including reopening healthcare.gov for a second enrollment period this year through August 15th. Most states that run their own marketplaces have followed suit. New estimates out today from HHS show that more than 500,000 people have actually signed up through this new open enrollment period. They've also allocated $100 million for advertising in the marketplaces, which the Trump administration had mostly ended. They've reinstated $2.3 million for navigators who help people enroll in marketplace plans. The Trump administration had cut more than $50 million from this program. And they've issued executive orders directing federal agencies to reverse Trump-era regulations that had undermined the marketplaces, along with other fixes. The recently passed American Rescue Plan addresses the affordability problem expressed by many uninsured adults with the most substantial expansion of marketplace premium subsidies since the passage of the Affordable Care Act. The ARP temporarily enhances marketplace subsidies across the income distribution, including zero premium plans for people up to 150% of poverty and capped premiums for people with incomes over 400% of poverty at 8.5% of income. It provides temporary insurance subsidies for people who lose their jobs, zero premium marketplace plans for people who file for unemployment insurance, and free premiums for COBRA coverage for workers who lose their job-based coverage through September 2021. And it provides significantly more federal funding to the 14 non-expansion states to encourage them to move forward. This subsidy schedule shows you the improvement in subsidies under the ARP relative to current law, relative to the ACA, but it doesn't address, the ARP does not address the cost sharing in marketplace plans. This is a bill that was introduced by Senator Jeanne Shaheen, which would also reduce cost sharing in marketplace plans. We are likely to see more congressional legislation and executive branch rulemaking this year that could expand coverage or increase the number of people who are enrolling in coverage. Additional reforms that would help reduce the number of uninsured adults include making the ARP premium subsidies permanent and improving the cost protection of marketplace plans, allowing people with incomes below poverty in Medicaid non-expansion states to enroll in marketplace plans, at least temporarily. Fixing the so-called family coverage glitch, which keeps dependents in high-cost plans, employer plans from accessing marketplace subsidies, fully reinstating funding for navigators and further expanding advertising and outreach efforts, encouraging enrollment in marketplace coverage and Medicaid by lifting enrollment barriers, simplifying plan choices, and letting eligible people enrolled in other public programs like food assistance typically automatically enroll in Medicaid. And offering a choice of a government-operated public plan through the marketplaces and creating a mechanism that would automatically enroll uninsured people and potentially allowing people with offers of employer coverage to enroll in a public plan. So this is going to continue to be an extremely interesting year in coverage policy, and we're likely to see a drop in the uninsured across the country as a result of these changes. The question, of course, is always how far we can get towards universal coverage. And I'll stop there and look forward to your questions. Thank you.
Thank you. Thank you very much. We have had some questions. Some of those were related to the prior speakers. So we're just going to pause here and take a few of these questions. So some of them are for Dr. Collins, some of them are for HPIO staff. And while we're doing that, I'd like to encourage you to maybe take an opportunity to stand up and stretch. See, like it helps you to stay alert and energized if you're standing up a bit during the presentation. So one question that is has been posed is, I think maybe perhaps both for HPIO and for Dr. Collins, and that is access simply a measure of coverage or also related to the presence of healthcare providers? So if somebody could please respond to that question.
Sure, I can just provide an answer from the perspective of the dashboard. And in the dashboard profile on access to care, excuse me, we do have measures of coverage. So uninsured rate, the percentage of people who have work at a company that offers health insurance, but we also have measures of access to primary care, access to behavioral health, access to oral health, as well as measures of workforce, and particularly the percentage of need that's not met in healthcare professional shortage areas. So in that domain, we have a total of 5 domains, so take sort of a broader look at access to care.
Hey, great. Thank you, Zach. Here's a question that I think perhaps Dr. Collins could contribute to answering, and that is, what role is increasing consolidation in the healthcare industry contributing to healthcare spending and cost?
So just like I said, the evidence really does show that higher prices are driving healthcare costs. And one cause of those higher prices is consolidation in local markets. So markets that tend to have fewer numbers of providers, less competition, tend to have higher prices. But there's just enormous variability across the country, even within the same state. I mean, if you looked across Ohio, I'm sure you'd see a lot of variability in the numbers that I showed for the average, but consolidation is a major reason.
Great. Thank you, Dr. Collins. And I'll just draw your attention to the fact that we have responded to some of the questions in the question box, just responded in writing since we have limited time this morning. We'll hopefully have a chance to answer more of these questions later on, but if you end up not having your question answered and you want to reach out to us after today's webinar, we'd be happy to have further conversation. So now we're going to move on to the next speaker in our lineup, and that is Catherine Robb. Catherine is the Senior Program Manager for Environmental Health at the American Public Health Association. She's going to go deeper into achieving health equity and the power of policy to get us to those improvements. So, Catherine, it's your turn.
Wonderful. Thank you so much for having me here today. I feel like I'm already learning so much, and I'm looking forward to hearing the next presenter as well. So let me just see here if I can click on over. There we go. So as you heard, I'll be talking about looking forward to achieve health equity. But before we get started, for folks who don't know, the American Public Health Association is based in DC, and we're a national nonprofit of public health professionals. And our mission is to improve the health of the public and achieve equity in health status. And we've heard equity a lot today, and I'm sure you all have probably seen some version of this graphic, but I like sharing it at the top of presentations because it shows that equality and equity are different, even though they're sometimes used interchangeably. So equality is giving everyone the same thing. As you can see on the top, everyone gets the same size bike, but it only really fits one of them. And by equity, we mean providing resources according to need. Health equity can be defined in many ways, and I know HPIO also has a definition. The one I'm presenting here just shows that all definitions include a focus on ensuring opportunities for everyone to attain their highest level of health. And to achieve health equity, obstacles to health must be removed, such as poverty and discrimination, and their consequences, such as powerlessness and lack of access to quality education. And as we saw on a graphic earlier in today's presentation, we know that health is more than just what happens in the doctor's office. And the social determinants of health are the conditions in which we live, work, learn, play, pray, are born. And these conditions include a broad range of socioeconomic and environmental factors, such as air and water quality, quality of the built environment, opportunities for employment, income, early childhood development and education, access to healthy foods, health insurance coverage, access to healthcare services, safety from crime and violence, culturally and linguistically appropriate services in all sectors, protection against institutionalized forms of racism and discrimination. And inequities often stem from structural racism or the historical disenfranchisement and discrimination of particular marginalized groups. That includes racial and ethnic minorities, low-income populations, and members of LGBTQ community. These groups have historically been withheld from obtaining resources that are needed to be healthy and are disproportionately exposed to a combination of health risks such as poverty, violence, poor neighborhood conditions, and environmental health hazards. So another term that people are increasingly using is the political determinants of health. And this definition I have here is from Professor Dahl's Political Determinants of Health book. The World Health Organization also had in their Commission of Social Determinants of Health report a while back stated that health is shaped ultimately by the distribution of money, power, and resources at a global, national, and local level, all of which are political decisions. And it's just calling attention to the fact that social determinants of health include historical and continuing political injustices. So another way of looking at this is presented from Change Lab Solutions in their blueprint for change makers achieving health equity through law and policies. It's the 5 fundamental drivers of health inequity. Structural discrimination operates similarly through policies, cultural norms, and institutional practices, but accounts for how multiple dimensions of identity and institutional and interlocking systems of oppression shape individual experience. Other fundamental drivers are income inequality and poverty. Wealth can determine families who have access and can afford basic resources and services. Inequitable disparities in opportunity could be like inequitable access to quality education and economic opportunities. Disparities in political power, families and individuals with little political power find it difficult to make their problems and needs visible to government and institutional decision makers. And then governance structures determine how power is distributed and exercised in decision making that shape places as well as access to resources and opportunities. So now that I've set the stage, if you will, I'm going to go into just 3 social determinants of health to give examples of why they're so important to health, and then what are some of the inequities we're seeing associated with that. So the first one is transportation. As you can see, it provides access to jobs, healthcare, grocery stores, medical appointments, connects us to communities. Public transit in particular is very helpful for reducing air pollution, vehicle crashes, increasing physical activities. We know inequities resulting from transportation and land use decision has disparate adverse effects on the health of racial minorities, lower income individuals, older adults, people with disabilities, and women. The greatest barrier for low-income populations for disabilities, and communities of color is that lack of transportation options, which can be a barrier to employment. At least, and this is nationally, at least 12 million individuals living in rural communities, 41% of the rural population, live in counties with no public transportation. And rural residents with disabilities and those who serve them report the lack of transportation as one of their most significant and persistent problems. And of course, lack of transportation access is associated with lack of regular medical care, missed appointments, and less healthcare use. Housing, typically there's 4 pathways that connect housing and health. And it's for decades, we've seen policies that have limited housing options and economic opportunities, particularly for communities of color. These policies and practices include redlining, exclusionary zoning, racist restrictive covenants, gentrification, and discriminatory lending practices. And because of structural racism, certain groups are more likely to experience housing instability and live in neighborhoods with limited resources and poor quality conditions. I won't go through all the pathways, but did want to flag affordability. We're in a housing affordability crisis right now, and unaffordable housing hinders a household's overall ability to pay for necessities that support good health, such as healthy food, healthcare visits, energy and home maintenance. And there's also racial disparities that exist among those who are cost burdened. The last social determinant of health I wanted to touch upon is education. We know it is incredibly strongly linked with life expectancy, healthy behaviors, and employment. And access to quality early childhood education increases likelihood to graduate from high school, but the access to high quality preschool varies by race, income, and geography. There are not currently enough spots in subsidized preschools for more than 3.4 million preschool to age children living in poverty. Early child care is critically underfunded in the US, and Black and Latinx children are often closed out of high quality public preschool programs. 1 in 4 of 13.5 million US children of preschool age live below the federal poverty line. And despite increased state investments in subsidized early childhood education for low-income community, there is still an extreme ongoing unmet need. And as we heard about ACEs, many young children are exposed to traumatic life events. Almost half of children in the US have experienced one or more types of trauma, and children of families at all levels, of all economic levels, experience trauma, but early childhood trauma occurs more often in families facing financial hardships. And trauma impacts brain development, cognitive development and learning, social emotional development, and ability to form and maintain secure attachment relationships. So what are some approaches that we can use to advance health equity? But before digging a little deeper into these, I'm going to suggest 3 principles of action. One is to improve the conditions of daily life, the circumstances in which people are born, grow, live, work, and age. Number 2, tackle the inequitable distribution of power, money, and resources, the structural drivers of those conditions of daily life. And number 3, measure the problem, evaluate action, expand the knowledge base, and develop a workforce trained in social determinants of health and political determinants of health, and really raise awareness about that. As you can see, there's just a few approaches I listed. There are plenty more, but it's very important to work across sector and have it be place-based partnerships to address what's happening. You could try with a health and all policies approach, which is a strategy for addressing the complex factors that influence health and equity. Start conducting equity impact assessments, which is a support tool for building policy coherence for health equity. It's used to assess potential health equity consequences of policy, and then it feeds back into the decision-making process. And I should have listed this one first: involve community residents in policy process. Involve them every step of the way. Community members are well aware of the barriers that they face, and they are so aware too of what could help them to succeed. So include them in the process. And also apply a racial equity lens, and I'll go into this a little bit more in my next slide. What does that mean? What does apply a racial equity lens mean? And that means exactly what I have listed on the slide: process of paying disciplined attention to race and ethnicity while analyzing problems, looking for solutions, and defining success. Don't do the colorblind approach. Colorblindness perpetuates systems of disadvantage, and it prevents structural racism from being acknowledged. And some examples of who's using racial equity lens right now, I can provide a couple. So in Minneapolis, they're evaluating their city charter and all city policies and procedures to prioritize racial equity. In Allegheny County, they're advocating for policies that improve health for communities of color, including a Black Mamas Matter policy agenda. In Douglas County, Nebraska, they're committing to conducting all HR, vendor selection, and grant management activities with a racial equity lens, including reviewing all internal policies and practices such as hiring, promotions, leadership appointments, and funding. And taking this one step further, Here are some examples on the left of applying a racial equity lens and what that looks like. And then you can apply a racial justice lens, which brings into view the confrontation of power, the redistribution of resources, and the systemic transformation necessary for change. It requires fundamental changes that reposition communities of color in relation to power and resources, which includes being able to challenge and shape the many institutions that determine a community's conditions. So I told you about the inequities and the bad, if you will, of the social determinants of health of the three: transportation, housing, education. So here are some ways that you can work toward equity. The first one I have here is adopt policies promoting multimodal options. And I feel now that I probably should have put accessible options. For example, for the complete streets provisions, which ensure that the entire roadway is designed with all users in mind, it's important to make streets and public rights of way safe and accessible for everyone, including people with disabilities. The next suggestion is to prioritize transportation investments in low-income communities and communities of color, and to make sure that it really connects to housing to jobs, to local services, healthy foods, medical care, other basic services. And also, this not only speaks to prioritizing investments of creating new transportation infrastructure, but also maintenance. And then the last one here is expand public transportation and equitable transit-oriented development. For the housing equity, eliminate racist restrictive covenants in housing and property deeds, advocate for healthcare financing for healthy homes initiatives such as Medicaid reimbursement for healthy home services, implement proactive housing inspections rather than putting that burden on potentially renters who have many other things that they're juggling in their lives, advocate for better tenant protection, establish community land trusts, and this really enables low and moderate income communities to build equity through home ownership. And typically, 1/3 of community land trust board is made up of community residents. So it's really helping them be part of the decision-making process as well. And then educational equity, I grabbed this. This is a screenshot from the same report I referenced earlier from Change Lab Solutions, but I am going to focus specifically on the trauma-informed social emotional learning piece. And this just means adults are able to recognize and respond to the impact of trauma on young children and infuse trauma awareness, knowledge, and skills in program culture, policies, and practices. And some recommendations to doing this is strengthen early care and education workforce by increasing professionals' capacity to provide trauma-informed care, expand initiatives that help early care and education programs connect families with community services, and provide children who have experienced trauma with high quality, stable early care and education and strong early learning supports. Also for the universal preschool, an example of where this has been happening for quite a bit of time, quite a long time, is in Oklahoma. They're one of the first states to offer universal preschool for 4-year-olds. The Oklahoma preschool program initially enrolled 9,000 children in 1998 and has since expanded access to 40,000 children, and it follows best practices surrounding provision of high quality standards, including a maintaining student-teacher ratio of 10:1, capping class sizes at 20 children or fewer with 2 children. Definitely check them out if this is a route you want to go. And access to health quality universal preschool has the potential to create an education system that is more supportive of and responsive to communities of color that can improve overall health outcomes in these communities. So I just wanted to end my presentation to share a couple of APHA resources. If you're not already familiar or want to explore more about racism specifically, This book here that I have pictured is a really wonderful resource that came out about 3 years ago, I believe. We recently hosted Advancing Racial Equity webinar series, which digs a little bit deeper into racism and health and various topics of 6 topics. We have a health equity fact sheet series, one specifically focusing on housing and structural racism and what you can do about it. And then also reach out to your APHA affiliate colleagues. I know Ohio is very strong, the Ohio Public Health Association. And the affiliates recently launched an equity, diversity, and inclusion self-assessment toolkit of looking organizationally. And lastly, I just want to thank Tia Taylor-Williams, who's the director of the Center for Public Health Policy and Center for School Health Education, who is leading this work at APHA. Thank you so much.
Thank you, Catherine. I want to just mention you were talking about the equity impact assessments, and I do know of a philanthropic organization that is funding an equity audit in a county in Ohio. I don't believe that that's been completed yet or released yet, so I'm not going to mention which county, but I thought that seemed like an encouraging sign and an example of public-private partnership to address inequities and disparities. Let's see, I'm not seeing any questions for Catherine. So I think we'll move on to our next speaker. And again, I just want to thank all of you for joining us today. We've had very strong attendance and engagement, so we appreciate that. We're going to close out today's session with a presentation from Melinda Dutton, who's a partner at Manette Health. She's going to talk about next steps for health value beyond the pandemic. So Melinda, we look forward to hearing your insights.
Great, thanks so much, Amy. So let me see if I can advance our deck here.
Sometimes there's a slight lag.
There we go. Well, thank you so much for having me, Amy, and really congratulations to the Health Policy Institute of Ohio on the release of the dashboard. It's really such thoughtful and thought-provoking work. And I know as I was reflecting on my comments today, just having that rich context made me more focused in terms of the discussion. So what I'm going to talk about today, I'm going to get a little tactical. We're going to talk about 7 strategies for states who are looking to buy health, not just health care. This work is a continuation of the discussion that we've been having around social determinants of health, or what we sometimes describe as drivers of health. There's actually been some polling that drivers of health is more reflective of what people in the community think of as what these factors are that we describe. They are broader than social. They're the social and economic and physical, environmental, behavioral factors that influence health. And we've seen variations on this theme throughout all the presentations today, which is that actually just a small percentage of health outcomes are driven by healthcare itself. So while health coverage is critical, healthcare access is foundational, it's not sufficient, and we need to look more broadly when we are trying to actually improve health. This report that I'm going to be talking about today was funded with support from the Commonwealth Fund and the Blue Shield Foundation of California Foundation. And it was inspired in part and in collaboration with work that's been happening in a number of states, and specifically North Carolina, which is a state that I provide support to. But I work with lots of different states who are similarly struggling to figure out how do they get more value from their investments and how to improve the health of their population. And whether those states are trying to bend the cost curve or flatten the cost curve, that there is a common and increasing understanding that in order to do that, they need to look beyond kind of traditional models of value-based purchasing and think about new ways to influence health outcomes. This imperative has only been become more urgent in the wake of the pandemic. The pandemic not only created a health crisis for our country, it created an economic crisis, and it really brought into stark relief the enormous health disparities, particularly racial disparities, but also economic disparities that pre-existed the pandemic, but were certainly exacerbated through the course of the pandemic. And so the impetus of this work was to say, okay, let's step back. Let's put a lens both to our federal partners, and there's a companion report that focuses on what the Biden administration can do to invest in health. But for this report, we focused on what states can do to leverage their enormous purchasing power, their regulatory authority, their interagency partnerships, their bully pulpit. So what can states do to really change the paradigm about what we can and what we think of doing and what types of interventions we entertain to improve health? Because states have control such a large share of the healthcare spend, in addition, through their Medicaid programs, through their purchasing of employee benefits, in addition to their regulatory authority and their bully pulpit, we believe states are really kind of at the foundation of changing the paradigm for what it means to improve health. Okay, so we outlined 7 strategies, and I'm going to go through those briefly, one by one. The report itself gives more fulsome discussions of those strategies and more examples. Here I've just pulled out a couple of examples from states, and these aren't the only states who are adopting these strategies, but they give you an entry point if you're interested in learning more. So the first strategy we're recommending is around integrating social determinants or drivers of health into states' plans to combat COVID-19. Frankly, this sounds almost obvious. I mean, we saw with the public health crisis that if you didn't have adequate food or stable housing, you couldn't isolate. You couldn't protect yourself from infection or prevent yourself from being a part of spread. If your social environment was so unstable that you didn't have a safe place to stay, you didn't have the kinds of social supports or financial supports that enabled you to have adequate access to food. And we saw that multiple states used coronavirus relief funds and other resources to dramatically accelerate the social supports that they were providing to their most vulnerable populations, including housing supports, meal delivery programs. And there was that direct relationship between those basic fundamental needs, the public health imperative, and the health of those individuals who were participating in those programs. We've seen now that as the pandemic has continued and spread continues to be a high priority, but also as we're looking towards a post-pandemic, God willing, environment, and where states are looking at emerging from the current crisis and increasing desire to figure out how to maintain that integration going forward. And certainly the influx of funds through the American Relief Plan provide an opportunity for states to think about how they can sustain those interventions that have been successful in addressing public health, individual health, and social and economic needs for populations in a more cohesive way. Our second strategy is around payment policies. And, you know, this one could be its own, we could break this out into its own paper, and in fact have in other contexts. But a foundational challenge that we have in our healthcare system is that it incentivizes first volume, and even to the extent that we've moved away from volume and tried to incentivize outcomes in healthcare, those incentives have really been structured around healthcare delivery. They really haven't been structured around the larger influences that impact health and health outcomes. And so we are recommending that states really step back and think about how they, as payers, can change their relationships and their expectations with their managed care partners, with the provider systems, and enable those partners to experience the financial incentives of having a broader view of what it means to improve health. So we've provided a couple of examples here. Massachusetts and Minnesota have both pursued risk adjustment models that integrate social risk factors into their payment systems. So in Minnesota for their ACOs, in Massachusetts for their managed care organizations, they've said we are going to change our fundamental payment structure so that we are considering that the costs that are involved in addressing social risk factors in an effort to improve health. There are many, many different ways that states can do this. And in fact, CMS in January released a 50-page document that said, here are all the authorities under Medicaid that states can leverage in order to address drivers of health in the context of their Medicaid programs. But it's still pretty complex, and there's a lot of experimentation happening here. So one of the things we recommend in our federal paper is for more federal guidance and more federal support, and frankly, some more flexibility to states to embed interventions for social drivers that have a direct impact on health into healthcare reimbursement more broadly. Our third recommendation is around developing shared assets and resources to enable interventions addressing drivers of health. And what do we mean by shared assets? Well, right now, we have evolved to a place where we have more interoperability among our healthcare payers and providers so that we can exchange information about health, and we do a better job than we did 10 years ago understanding what is driving healthcare at costs and outcomes. What we don't have is a system that is inclusive of the social services and other programs that also are serving the same population and frankly can have even more of an impact on those health outcomes than healthcare interventions. So we've seen multiple efforts within states and within targeted efforts, private efforts as well, to create new sets of shared assets that enable the exchange of information, such as closed-loop referral platforms that enable providers to refer individuals to social service providers and then follow up to ensure that their needs are being met and have that those social service delivery be able to inform the physical health and vice versa in terms of supporting populations. We've also seen new partnerships, and Kate was just talking about the importance of interventions really reflecting the input of community, and this is incredibly important in this context. So we've seen, like in New Jersey, they've recently created these regional health hubs that are supported by the state's Office of Medicaid Innovation. Michigan and Mexico have focused on workforce issues and what kinds of new workers do we need to bring to support our interventions that go beyond the four walls of the doctor's office. So these are the types of shared assets. They can be information platforms, they can be networks of providers, they can be new types of trained workforce that we can bring to bear on new types of interventions to address the broader issues that impact health outcomes. Our fourth strategy is around maximizing participation in public programs that address the drivers of health. So first and foremost, this is about ensuring access to coverage, as Sarah was speaking about earlier. And in our report, we recommend that states step back and look at the extent to which their Medicaid programs, CHIP programs, are creating unnecessary barriers to enrollment among eligible populations. The graphic that Sarah showed shows us that we could go a very long way towards reducing the number of uninsured if we just ensure that people who are currently eligible were enrolled in those programs. And of course, Medicaid expansion is critical here as well. Families who are able to get access to Medicaid coverage and are currently uninsured not only have better access to health care, they have less financial stress in their life and are able to use resources for food and other basics that otherwise would be dedicated to their care. But we encourage states to go beyond that, to really look at the intersection between SNAP, between WIC, between LIHEAP and other sorts of programs that provide family basic supports. Access to food has been shown over and over again to have a direct impact on outcomes for populations. And so maximizing participation in those programs, again, as I said with Medicaid, not only provides a direct intervention for that social need, it frees up income within the family to have to create more stable environments across the continuum of social and healthcare factors that impact their health outcomes. Our fifth strategy is around creating standards for quality utilization and outcome measurement. And I'm going to be honest, this one's really tough. We don't have a standardized set of measures of reporting requirements, And I know states are really struggling with this. I was recently working with one state who put reporting requirements in their managed care contract, and what they got back was it was very hard for them to decipher what this was really telling them. And so they're in the process of further honing those. But it's critical that states take this as they're integrating requirements into their managed care contracts, into relationships with providers. It's critical that we start somewhere with the quality, utilization, and outcome measurement standardization within states. And there are federal efforts that are underway to try to accelerate this. But states shouldn't wait for those efforts. They should be trying to really tether tightly accountability within their existing relationships for outcomes. And we give Rhode Island as an example here. Lots of states require screening for drivers of health. Rhode Island is an example that makes this a core part of their quality reporting requirements and holds plans accountable for meeting those standards. Our sixth strategy is around making drivers of health central to innovation agendas within the state. And here I cite North Carolina. I could cite also Indiana. There are a handful of states who have come out and said, we are taking an integrated approach to our efforts to improve health. In North Carolina, they call it buying health, not healthcare. In Indiana, they call it their Healthy Opportunities Initiative. But these are more comprehensive areas to step back and say, how are we working together across the multiple levers that we as state government have in order to drive investments in integrated ways to improve health and coordinated ways to improve health. There's an enormous opportunity, as I said before, with the American Relief Plan. States right now are scrambling to figure out how that influx of funds is best used strategically, and so that it's not a one-off, so that it creates a glide path towards more sustainable change. Having a focus on health and on investing in health is a great organizing principle to help drive that work forward. And then finally, incentivizing community accountability and stewardship. And what we mean here is that in addition to being critical partners in delivering healthcare or paying for healthcare, healthcare providers and plans are also critical parts of our community. And so how can we incentivize our provider and payer and plan partners to be good stewards of our public funds, to invest in those communities, either directly as it relates to interventions for specific Medicaid populations, or more generally in terms of their, what are their own payment policies for their own employees? To what extent are they collaborating directly with the communities that they're trying to serve? So creating new mechanisms to incentivize community accountability and stewardship is a seventh strategy that we're encouraging states to consider. And I call out here Arizona and Oregon, who both have provisions in their managed care contracts that require some level of reinvestment from their managed care organizations. And I noticed that in Ohio's new procurement, the state has lifted that up as a strategy Ohio is going to be adopting as well, along with a couple of new requirements related to managed care organizations contracting and working within communities and collaboratively with communities around specific social or drivers of health investments, which I applaud and think is exactly the direction that states should be going. So here I just lift up in a little bit more detail on North Carolina, and I'll just say this. North Carolina is unique in that it was able to obtain a federal waiver for a 5-year pilot program, $650 million to invest, to use Medicaid dollars to purchase health-related services that have an evidence base of improving health outcomes. They're the only state who has that waiver. But what I will say is I think there are aspects of what North Carolina is doing that are more broadly applicable and that could provide resources for other states looking to similarly scale their interventions. And what we show here is that North Carolina has created a fee schedule for housing services, food nutrition services, and services specifically focused on ACEs. There's also transportation services that are included in their fee schedule, though we don't highlight it here. And that fee schedule is going to be used to pay community-based providers for the services that they're delivering to Medicaid beneficiaries as a direct in a direct effort to improve health outcomes. And that's something that is potentially leverageable in other states, because a critical component of these efforts is to ensure we have the community resources to meet the need. And then finally, where do we go from here? We recommend that we really focus on multi-year strategic planning processes and set for ourselves some attainable annual objectives in moving the efforts forward. As we've heard from the speakers today, this is a big issue, and we aren't going to achieve health equity. We aren't going to address all of the drivers of health overnight. We need to be able to hold ourselves accountable to making progress against those goals, and multi-year efforts are the way to start. In those efforts, it's really important to create a single vision and to align that vision internally and externally with stakeholders. As I said, in North Carolina, they call it buying health. And Indiana, they call it creating healthy opportunities. But they have each created mission statements around what that means to them that have been disseminated within their agencies and out to their communities and their partners to make it clear where what the North Star is of all of their efforts. Defining specific goals around market and agency progress and tracking the progress against those goals is critical. Interagency collaboration is just such an incredible opportunity that states have to bring together resources across food, housing, transportation, education, the various domains that are really driving our health outcomes. So the MCO partners I've already talked about as critical partners. And then finally, really leveraging that bully pulpit so that this isn't an initiative. It's really it's the state's vision that's shared not only within the department, but more broadly. So I've covered a lot of ground there. Let me pause here. And I just want to acknowledge my collaborators in the report, and I'll hand it over to you, Amy.
Great. Well, thank you. Thank you very much for a whirlwind presentation. You covered a lot of ground there. We did have we don't have much time for questions, but there's one that I wanted to share with you and get your thoughts on. We couldn't agree with you more about the need for accountability and evaluation of efforts. So I think this question pertains to that. You mentioned, I believe it might have been in the first strategy, states that prioritized the use of federal funds or Medicaid authorities for drivers of health supports. Are you aware of any steps those states have taken or other states have taken to measure the degree to which those resources are reaching racial and ethnic minorities or having the result of narrowing or eliminating disparities and inequities?
Yeah, so I would say a couple of things. One is I know of at least a couple of states who are implementing new requirements to report finer information on racial and race and ethnicity in their health and social determinants outcomes. I know that, for example, North Carolina was one of the states who used some of its coronavirus relief funds to disseminate resources to address social issues in the context of COVID. They did tracking related to race and ethnicity and that distribution. The data, I would say, on social determinants and there's a lot of data on the intersection between the social determinants and the health equity outcomes. I'm not aware of states who have put out specific studies related to that, but it certainly went back to that quality and reporting piece. One of our recommendations is that all of the reporting be segmented so that we can hold ourselves accountable from an equity perspective.
And that is an important first step, at least. Well, thank you again, and thanks to all of our presenters for your willingness to spend time with us here and reflect on where Ohio is in terms of health value. We want to close with a poll question here, and that is, overall, how would you rate the quality of today's forum? And just remember too that you are going to receive an email with an evaluation survey that is more in depth than this, but we just want to get a quick take on how you felt today's forum was. And, you know, I would like to just close by saying that while the evidence is, or the data is grim, we know that improvement is possible. We know that there are strategies that we could either implement or more fully deploy here in Ohio to get to improved health value. And we know that there are policymakers who care deeply about these issues and are working diligently. There's people within state government. There are legislators who are working very hard to look at the evidence and advance policy changes that could impact health value and reduce or eliminate disparities and inequities. Those policymakers need to hear from their constituents and others who influence the policymaking process. So we have a slide up right now that has a few examples of ways that you can influence the policymaking process, that you can engage in this process. Remember that our elected officials exist to serve us and need to hear from all of us regarding what gaps we see in communities throughout our state. So thank you again for attending our webinar. Please take that short survey that you'll receive after today's forum and share any feedback you have regarding today's event. I hope you enjoy the beautiful weather, get out for a walk, and take care.